people can come with quite proactive desires for normal birth, but if they encounter a model that's highly medicalised, many of them will adjust their behaviours to take that on. And so there's a really interesting idea called the irresistible biomedical metaphor of birth. So this is research from the Scandinavian countries that show women can come with an orientation to normal birth, but when they encounter that biomedical model, they adjust their expectations and almost, to some extent, passively accept that the service works in this way, and they have to adjust their expectations to fit in. So we know there's quite a lot of pressure to comply with what the service offers. There's also something called what's experienced is best, which is a well-known research phenomena that says that women expect when they encounter the maternity services that the care they'll get must be the best that's out there, because why would the service be set up for an inferior model? So in other words, depending again on the service, they kind of accept that that's what's there, that's what I have to accept. When we see them having alternative experiences with different models, that of course changes it dramatically, because then they have something to compare against. And this is a really key feature of continuity models of care, where women who encounter models that deliver really good continuity through all phases of care say, what was I missing out on that I didn't have this the last time? You know, they're really clearly seeing that they're models that are superior to others. But that's an issue, you know. In a first birth, you've got no comparator to look against apart from your peer group's experience, I guess. So it kind of worries me a little bit that we don't have optimum models up front there that women can engage with, confidently knowing that that's probably the best model that is out there.
What do you think women need to be aware of, or parents in fact need to be aware of, as regards place of birth? Mm-hmm. When they're making that decision, what would you say are sort of key things?
I mean, there's going to be almost certainly there's going to be a significant shift in the next couple of months, because the NICE intrapartum guideline group that set guidelines for the whole country are issuing new guidance on place of birth that's going to promote midwifery units and home birth for women who are low risk, if I can use that phrase. So what's going to happen, I mean, this won't happen overnight, and they're actually trying to do some research to see if we can maximise these options being presented on the ground. But what should happen is that women will be encouraged to think about birthing in those places for a range of reasons, you know, really good evidence reasons that shows they'll reduce their intervention rates, have a more positive experience, a safe experience for them and their baby. So, you know, that's going to be really quite interesting, because one of the parts of that sort of proposal is that for second and third babies, women are going to be asked to consider home birth. I mean, that's going to be quite a change, because that is a marginal choice at the moment, as you know, about 2%. So, you know, if a whole group of women coming back for second and third babies are being encouraged to think about home birth, it'll be very interesting to see how that plays out in terms of their actual choices. I mean, another thing we know really, this is from consumer groups like the NCT and others who've done research on preferences for birth, that actually a lot more women out there express an interest in home birth than actually end up birthing at home. And that's probably because what happens when they enter the service. So, you know, there may be 10 or 15% or something like that who'd say they'd be open to that idea. But when the option isn't really viable locally where they birth, then that reduces down to 2%.
I think that's quite a tricky question, but ultimately, wherever that woman feels safe. For some women that will be a hospital, and for other women that will be home or a birth centre.
In an ideal world, I think I would probably opt for a birth centre. I've heard some great things about birth centres, that they're much more homely, much more kind of open and holistic approach to labour and to birth. So I think I'd probably opt for that.
It's obviously much less medicalised in a birthing centre, and the practices that the midwives use are, well, just seem much more natural. In hospital, I ended up giving birth on my back with my feet in stirrups, which was one of my not so positive experiences. And then in the birthing centre, I was on my knees and I was squatting and things like that, and it just felt so much more. It felt right. It felt like what I should be doing, and so I suppose those are the differences. And I suppose, a hospital environment can be a bit frightening sometimes. I was induced at 38 weeks because of preeclampsia. And so I was suddenly just in the hands of the hospital and the doctors and the midwives there, and I didn't know what to expect. Whereas in the birthing centre, I luckily hadn't got preeclampsia the second time round, and it meant that I could just, it all happened naturally. I went into labour naturally, and and then the whole thing ended up being a much more natural experience.
My first baby was born at a birth center, and my husband and I really enjoyed that experience. I'm not a huge fan of hospitals. I feel very uncomfortable in hospitals, and this seemed like a happy medium between having the baby at home and having the baby at the hospital. We were attached to the hospital, but not necessarily part of it. It was midwife-led, and what we also enjoyed is the having the room to ourselves afterwards. It was a double bed with an ensuite bathroom, and we had that private zone to just be a family for the first time. We also really enjoyed the mood, the environment within the birth center. It was very positive, and I felt very safe. I felt very safe there because I knew that if something were to have gone wrong, we were very close to medical help. So if we were going down that path again, I would definitely choose a birth center all over. Yeah.
The evidence is leading us now towards the conclusion that home, for a woman having her second baby, is probably the most sensible choice. Now, when you think that home, with all of the advantages of it being your space, you being in control, you can eat when you want, you can have music on, you can burn incense if you want, you can do anything you want at home. You can have a bath without being asked. The whole power dynamics between professional and you are reversed because it's your house. The chances of oxytocin being able to thrive in that environment are just profoundly more likely than stepping into a sterile, bright building and taking your knickers off the people you've never met before. I would say that everyone should look closely, think carefully about deciding for home in terms of birth. And that would be, for me, the optimum choice. If that's not available to you, then second choice would be a midwifery-led birthing unit.
Oxytocin is an absolutely amazing hormone. It's what starts labour and what makes labour continue. And we know that it's really, really important that women are in an environment where they're able to produce lots of oxytocin. So that means feeling safe. It means feeling kind of loved and respected in their birth space, so they're not scared about what's happening. Because on the other side is the adrenaline that will reduce the amount of oxytocin that the woman is producing. And she'll be producing adrenaline if she doesn't know where she is, if the environment's scary, if just things are happening that she doesn't really know what's going on. So we really want to encourage oxytocin.
When a woman is fearful during pregnancy, and particularly when she goes into labour, she produces more adrenaline. And adrenaline is actually important when we're afraid because it's the fight or flight hormone that helps us to respond to an emergency. But it can be counterproductive when a woman's going into labour because it actually inhibits the hormone of labour, which is oxytocin. So labour can stop or become slower. And I've seen this happen all throughout my career. When a woman has been labouring normally at home, then she transfers into hospital to have a baby. She goes in and rings up to say she's having contractions, and she comes in. And by the time she's gone through the hospital and she enters a different environment that may be looking slightly medical or clinical, then her labour can stop, or it can just come very, very slow. So it's important that we remember that and that we try to make environments as home-like as possible and as least clinical as possible. And if we can't do that, then midwives and all healthcare professionals that work with women during the childbirth experience are intuitive to how women are feeling and try to reassure them and encourage them and be as positive as possible, reinforcing with the language we use and the support that we give.
We know for sure, and there's some things that I will always say if I'm talking to couples or groups. I'll always say, isn't it great, isn't it good to know that we are the pinnacle of evolutionary selection. We know for sure that we come from a long line of effectively birthing women. How do we know that? Because if we didn't, we wouldn't be here. You can take it to the bank. Well, taking it to the bank is not a good analogy these days, but you know what I mean. We know for sure that we represent the pinnacle of evolutionary development, so we can be confident that we can birth well. So I think that's the first thing. The first thing to realise is that we have what it takes to give birth. I think the second thing to take on board is an understanding that all of this stuff that we've got around measuring birth, latent phase, first stage, second stage, third, this measurement is made up. And then we forgot that we made it up. And doctors and midwives act like it's real. I think so that's important to note that. Because if you choose to give birth in hospital, they're almost certainly going to be using that as their reference points. But in reality, birth is a narrative. It's a story that's unfolding. So I think, firstly, it's an unwavering belief in a woman's ability to birth well. Secondly, kind of a loose grip upon so-called a loose grip upon the belief of a professional's so-called expertise around knowing what's best for you. And thirdly, I would say environment management. We know for sure that the part of the brain responsible for the release of the hormones that we need to be abundant for birth, I think it's the limbic system. It's the part of the brain that's a lot older than the neocortex. It's probably 200,000 years old, whereas the neocortex is 10,000 years old. The neocortex is kind of where we get our reasoning brain, our thinking, our words, and all that kind of stuff. The limbic system is that part of the brain that's under the control of the unconscious mind. You can't talk to it. A woman has to be in an environment whereby her body is encouraged to lose itself to that part of the brain. So things like privacy, things like dark environments, dim lights, making sure that she's not cold, that she's warm, making sure that she's not asked ridiculous questions at inappropriate times or being put in a position where she has to speak or say anything. These are the kind of environmental factors that are really important. Michel Odent says that that orgasm and birth are one event separated by time. So the environment conducive for orgasm is the environment that's going to be best for birth. So unless you're into, exotic sexual practices, that probably means all of the things that we've spoken about: privacy, warmth. You imagine that you're approaching orgasm. Your heart is beating, you're breathing harder, you're enjoying the experience, and suddenly someone says, are you going to have vitamin K for your baby? It's going to affect the experience. So I would say they were the three things that are most important when it comes to having great birth.
My views on place of birth are that women should have the option to choose where she gives birth to her baby. And that doesn't have to it doesn't have to cost a lot of money. It doesn't have to be elaborate. It just has to be the simple choice of where to give birth, just as it should be, if at all possible, a choice where you die. And so for example, if one of my relatives knew they were dying and they wanted to go in a hospice, that hospice should be available. And if they want to die at home, then they should be allowed to die at home. That should be their right, to have the death that they want. But there are sometimes things that stand in the way of that. So medical problems, or even so with birth and death, it's exactly the same, that it's impossible for that to happen. And so I do think that there's sometimes that the choice isn't always there. But when at all possible, I do think that everybody should have the choice to have their baby either at home or in hospital or in a birth centre. And birth centres seem to be sometimes the middle ground between home and hospital. And certainly in my experience, I've found that they are an absolute catalyst, not only for promoting positive birth experience, positive outcomes for low-risk women, but they're also a catalyst for change, to try to change the way we deliver services in hospital. So I really believe that all women should have a choice, and I do believe that the recent publication of the NICE guidelines should help us to promote that choice and to make sure that services offer all three choices of place of birth. Because what the NICE guidelines are saying, that for low-risk women, for women with that aren't expecting any complications, actually to have your baby outside of a hospital is as safe, and also you're at less risk of having any unnecessary interventions. So there's just a small risk with the baby for first-time mums with out-of-hospital birth, with home birth actually. But to be honest, the risk is so small. And when we look at the risks of unnecessary intervention that sometimes lead to mortality, morbidity and mortality, then we have to balance those risks up with the risks of having a baby in hospital.